untolerated and outdated, misaligned, and in some cases, borderline criminal fee-for-service payment model far too long. This system creates financial incentives for higher cost and a bias towards more tests, more visits, more treatments, more surgeries, more of everything billable, except lower costs and better outcomes for patients.
We have to do things differently. A redesign. We need to end fee-for-service payment models and adopt a value-based approach so providers are incented to do the right thing.
This is why we've been hearing all day about moving from volume to value, moving away from fee-for-service. Fee-for-service is the kind of shackle that makes someone say, I only have 6 minutes per visit. So once you change the shackles of fee-for-service, you can unleash kind of attention where and how and with the intensity that's necessary, and that's how I think you can have that kind of conversation.
I would talk to a lot of healthcare executives who talked about the payment system in America like they were standing on two different boats. You have one foot in the fee-for-service world, one foot in the pay-for-value world, and it is obviously quite hard to balance between the two of those. Can you tell us a little bit, from your perspective about where we are in this transition to a value-based healthcare system?
We kind of continue to be in this transition, but in terms of, one foot on the dock and one in the boat is pulling away from the dock, is how I would describe it.
I think we know that it's directionally correct. We need to move to payment models that hold provider groups accountable for improving coordination, improving care, and lowering costs. And so I think because it's directionally correct, we need to get going. I think the thing that would accelerate it most is all of the commercial payers getting in the boat. And Medicare not pulling back.
Right.
This is about a changed relationship between payers and providers, from moving away from a kind of transactionally mediated, contractually mediated arrangement to an actual relationship. Can we actually look at the population that we are jointly serving and seeing what we can do to make things better?
And when I was at chair of the board of AARP and we talked to our members, the thing that I heard over and over again was the importance of a trusting relationship with a physician or a physician and the team.
The team of people are more engaged with each other, hopefully know the patient's history through some increased interoperability, are more engaged about thinking thoughtfully about appropriate site of care and costs.
It's a very team-based approach. We're taking care of patients from, through their hospitalization. We're really invested in how that patient does, and the idea that you would get paid piecemeal for things doesn't feel right.
How do we get to that point of no return, and are we at the place where we understand pay-for-value well enough?
It is incumbent upon payers like Anthem, like United, to create the business case for providers to want to get to that point.
I would hope that HHS and CMS would continue to support innovation on better care at lower cost for beneficiaries, and I think take advantage of the authority that's in the CMMI and maybe operating differently in this administration, but there's still significant flexibility to try new things.
I think a value-based system makes sense for everybody, and I think the surprise is for the practitioners as well.
We need to abolish fee-for-service billing and make value-based, results-oriented care a cornerstone of America's healthcare system. Then, and only then, will patients receive quality care at fair prices.